afternoon. I'll be presenting on Scapulothoracic dyskinesia, a concept review by Gilda et al., published this year in April. So scapulothoracic is not a true joint, but it's articulation between the scapula and thorax, sliding joint between the medial border of scapula and the ribs. So this is the movement. The primary movement is elevation and depression. Elevation is by the elevated scapula, and depression by pec minor. Rhomboid for the retraction, pec minor for the protraction, upward rotation by trapezius and also serratus anterior, downward rotation by rhomboid. But this is all the muscle that we call as periscapular muscle. So the action of the muscle actually is not isolated, but it is an interplay in between all the muscle in order to rotate or move the scapula. So the trapezius is a primary stabilizer of the scapula, a three portion, and the inferior function is to stabilize the arm during the complete elevation and throughout the descent from the elevation. Serratus anterior maintain the scapula flush to the thoracic cage, which will prevent the excessive internal rotation of scapula. So what is a scapular-humeral rhythm? It is a coordination between the humerus and also the scapular motion. So a ratio of 2:1 motion between the humerus and scapula is traditionally used, and for every 2 degrees of humeral flexion or abduction corresponding 1 degree of scapular upward rotation. And in this example, so if let's say the patient had a 180 degree of abduction, 120 degree is by the humerus, whereas 60 degrees is by the scapular rotation. However, recent studies have shown that this ratio actually varies greatly. This paper by Skibek, the scapular humeral rhythm for the entire arc of shoulder elevation was a ratio of 2.34 to 1, but actually ranged from 40.01 to 0.90 to 1 when assessed across a different increment of humeral elevation. So the scapula actually contributed most of the time in the shoulder elevation, around 50% or 90 to 120 degrees of shoulder elevation. So another study, this is a more, I think it's more painful study because they inserted the pin over 3.1 is clavicle.
Oh.
Yeah, to measure the angle. Clavicle, humerus at the insertion of deltoid, and one is at the scapular spine. So then they use the motion sensor to detect the rotation of the scapula and also the humerus. And they have come up with the ratio value of 2.4 for flexion, 2.2 for scaption, which is elevation, scapula, and abduction is 2.1. So it's around 2 something, the ratio. So what is scapulothoracic dyskinesis? Is occur when there's a noticeable disruption in the position and motion of scapula, which is typical, normal, and which can result in atypical and inefficient motion of arm and shoulder. So it can occur secondary to pathologies around the shoulder, or actually it can occur vice versa, meaning actually the situation can occur interchangeable. So these injuries can cause scapulothoracic injury, or the scapulothoracic injury can in turn cause this injury as well. But the weakness of the periscapular muscle is thought to be the progenitor of the scapulothoracic dyskinesia. And although there's no true direct correlation between these pathologies and scapulothoracic dyskinesia, but studies have shown that actually approximately 68 to 100% of individuals suffering from a known shoulder pathology also presented with scapulothoracic dyskinesia. So for the athletes, actually there's a 54.5% prevalence of scapulothoracic dyskinesia for the athletes who engage in overhead sports, whereas in non-overhead sports comprise of the 3.3%. And also, if the patient has excessive thoracic kyphosis and cervical lordosis, the patient may more prone to scapulothoracic dissociation. Female genital also more prone because they exhibit lower posterior tilt compared to healthy male at the high elevation angle. And also other predisposing factors, obesity and older age. So what clinical evaluation? What is the clinical evaluation? So there's no reliable clinical methods to diagnose scapulothoracic dyskinesia because of the 3D kinematics scapular motion, and also there's a lot of soft tissue surrounding the scapula, and this make it difficult for us to assess. So this is all the assessment and also the test. So the first three is the classification, basically macro and also all at all. It's basically just normal, subtle, obvious, or there's a present or absence. For keyboard is more systemic because they classify into 4 movements, 1 to 4. And type 1 actually is inferior medial scapular border is prominent. 2 is the medial border is more prominent dorsally. 3 is the superior border scapula elevated, and the scapula may also be anteriorly displaced. And 4 actually is normal, symmetrical. So coming to the test, so we have 5 tests here. So first is the scapular assisted test, where one hand is support the scapula, and the other hand is to support the inferior angle of the scapula, and ask the patient to abduct or flexion, whichever motion. Okay, so we do this actually to eliminate the cause of the scapulothoracic joint for the pain or decreased movement. So we do this test first. Ask the patient to elevate. So you ask the patient to abduct first. If the patient have pain or reduced movement, we do the test. So the patient pain or the range of motion improve, meaning it is positive. The second, is scapular retraction test. So first, the one on the hand stabilize scapula and clavicle, and the forearm actually is to press on the posterior scapula to produce a posterior tilt of the scapula, and this will stabilize the scapula, and we'll do a jog test. So let's say the pain was present before this maneuver, and after this maneuver, the pain is reduced, or the jog test, the strength of the supraspinatus is improved, meaning the test is positive. So lateral scapular slide test, actually this is assessing the excessive movement in the scapula in relation to the thoracic spine. 3 measurements are taken from the spine to thoracic level, inferior angle and superior angle to the thoracic level. Measure in 3 different positions. One at the when the upper limb is at side. Second is when the palm is at the waist and thumb at posteriorly. And third is when we are 90 degree abduction with anti-cam. So if there is a presence of more than 1.5 centimeter measurement variations, so it's indicative of the positive examination. So other 2 tests is to evaluate the pain and also muscular endurance. The first one is isometric scapular pinch test. We ask the patient to actively retract the scapula for 20 seconds. If let's say there's balance sensation, it's positive. And second is the push-up, wall push-up test. So ask the patient to perform 20 wall push-up. If there's a muscle fatigue, there will be visible medial scapular ringing, which means is positive. So this is the test, or the test that is for the scapulothoracic dissociation, but is still not very objectively. So treatment modalities, I'll bring you to one of the synonym, which is SSMP, which shoulder symptom modification procedure by Lewis. So this actually is a series of 4 mechanical techniques applied to the patient while it performs activities or movement that is most closely reproduce the symptom. So this is the chart, or what is a table that they are collecting in their paper. So first is a humeral head procedure. There are 4 procedures, right? Humeral head, changing scapular position, cervical thoracic region procedure, and also thoracic kyphosis technique. So they'll do this test each one of the procedure and find out what is the cause. Which procedure will alleviate or reduce the pain, and this will integrate it in the rehab program. Okay, so starting point, ask the patient to do a movement that will reproduce the pain. Then, once the proactive activity has been identified, the process, the SSMP process is commenced. Okay, then, but this the reason of procedure to reduce the symptom actually is not known. Okay, so first humeral head procedure is their aim is to influence the humeral head position. So they involve a series of pressure, push, or or muscle contraction technique. So this is a pressure technique. Use styrobrand or some clothes to reduce or pull the humeral head or push the humeral head. And ask the patient during this maneuver, ask the patient to perform the movement that will cause the pain. Okay, so this is muscle contraction procedure. This TheraBand asks the patient to make resistance, minimal resistance, and ask the patient to move for an abduction. The second one is the changing scapular position. So this is like how we do the test just now. So there's a manual technique to slightly modify the scapular position to see the symptom change during the, whether the symptom will change during the activating movement. So if manual technique not possible, then taping will be done. For cervical thoracic region procedure, so actually they say that cervical and thoracic also may have preferred pain to the shoulder. So a variety of procedure also applied to determine the effect on the patient activating movement. So they suggest that do the aggravating movement in single leg standing, tiptoe standing, and also gym ball sitting. For the thoracic kyphosis technique, they use the taping to reduce the kyphosis and us to perform the aggravating movement. So after all this procedure, I mean a minimum of 30% change from the baseline pain in the single or combination procedure is required for each of the for the procedure. So and also there should be a consistency of response. So meaning they test this SSMP at least twice and see whether it is consistent or not in the first and second visit. So a rehabilitation program based on these responses is formulated after this. So for treatment, basically conservative treatment is the mainstay, and there's two exercises. First is exercise aimed at improving the flexibility of joint, and second is focused on the scapular stabilization or muscle strength. So if there is a lack of soft tissue flexibility, physical therapy will be more focused on stretching of the scapular muscle and also around the joint. So if the underlying cause is due to the lack of muscle control, muscle strengthening exercise along with muscle control exercise is introduced. And two major targets is trapezius and also serratus anterior. Shoulder strap with upward rotation for the lower and upper trapezius, whereas push-up on stable surface is to increase the strength and control of the serratus anterior. So for summary, actually due to the significant variation in classification system and also lack of standardized diagnostic method, it remains difficult to evaluate scapulothoracic in dyskinesia in the clinical setting, and still the gold standard for treatment is targeted physical therapy. That's my presentation. Thank you.
Because of the scapulothoracic problem is very difficult to treat, to deal with, because many patients has like a muscle problem, imbalance. But first of all, you have to look for like an anatomical pathology, like a cup tear, lesion, or something like that, or even the compression cervical spine problem that cause of the scapulothoracic motion abnormality. But if nothing, you have to train the patient. But Benjamin Kibler tried to try to make it like to be more systematic, but still in the same way. Like you have to train the structure. Like if the patient has like a protect of the scapula or thoracic kyphosis, you have to correct that because scapular protection and kyphosis can increase load to the subclavian, and also it's not the good posture of the shoulder. And after that, you have to stretching of the thigh muscle around the shoulder that can cause the scapulothoracic problem, like a pec minor tightness or the latissimus dorsi tightness. That's it. That you have to stretching, and then you also have to promote the strengthening of the rotator cuff, perisca muscle, especially for the upper trap and serratus anterior. That is overall concept. The same concept.
Okay.
So the scapula in scapulothoracic is very complicated. It's like a floating bone. You need to be stabilized by the surrounding structures. Okay, so that's very complicated, and sometimes that may associate with the patient with multidirectional instability also. Okay, because these are the soft tissue problem. So key message is to do it conservatively. Okay, that is the treatment of most of the patients. The scapula train to protract forward, and the posterior structure will be stretched. Okay, you understand? The posterior is stretched because the scapula is protect to the front, so the anterior structure will be tight, like Ajahn Bon said. The pec minor, right, always very tight. So you need to stretch the pec minor by the sleeper stretch, right? By the pec minor stretching. I need to train the periscapular muscle in the back, okay, especially the serratus anterior, the trapezius, the lower tab, right? And also the periscapular muscles. That take long time to be better, and some patients very difficult to deal, especially if they have some syndromic problem. Okay, so sometimes it's very difficult, and some need to end up with the scapulothoracic fusion. Okay. Ajahn Bon, what about your experience with the scapulothoracic dyskinesia?
I have no experience for surgery in that kind of patient, but you have to know most of my patient I did conservative like Ben Kibler said, but as we know that our Thai population is not good for the strengthening exercise. When you let the patient try to do, and you let like a 1 or 2 month follow up, and you ask the patient, how about your training? The patient always forgot everything that you talk with him. So that is a problem. Sometimes you have to have like let the patient get like some personal trainer or something like that, but you write down the muscle that like a specific muscle that you have to want to train, like a strengthening of certain anterior, upper trapezius, stretching of the latissimus dorsi, and also pec minor or something like that. You have to write it down, let the patient remind themselves that that's my trick, but also the same, they don't do anything. That's medication and ask when should I improve, something like that. That is a problem. But fellow also need to know how to do some surgical method in this problem. If the patient has like a medial scapular problem, like a winking and weakness of certain anterior, by the way, they have the treatment option like a tendon transfer to do the certain anterior. They use some muscle to do like a certain anterior to repair certain anterior. They use like a trapezius or lower trap, something like that, to put it in the lower edge of the scapula. They have the technique to do. I never did it. And also they have the if the patient had like a lateral scapular winking by lumbar and trapezius weakness, they also have like a muscle tendon transfer or maybe plication to make it tight. And but even though if the patient still have the problem, they have scapulothoracic fusion also, but the result is just like a case series. They do the rib, the fusion scapula to the rib. It's the most surgical technique, but it's just in some cases by some centers. The muscle tendon transfer to collect the winking and scapulothoracic fusion.
Okay, very good, Dr. Lim. Good review.